Are you guys baseball fans? We have some baseball fans out there. Yay! All right. I was told this was kind of more of a spitball crowd, but we'll stick with baseball today. And I just learned that we have another individual here who has some experience with their World Series, so I'm really interested to hear about the commentary. So I want to just talk about our experience last year with the Giants World Series celebration in San Francisco, and hopefully this might be serve as some pointers for those of you who may have a million people show up in your town ready to celebrate. And I have to say, as a Giants fan and a baseball fan, the season is mercifully coming to an end for the Giants, but I wish the best of the luck to the other baseball fans out there. So let me tell you about better times, if you will. Back at the end of October. So on October 28th, there was some great baseball being played. The Giants swept the Tigers. Any Detroit people here? No? Oh, all right. Sorry, friend. But again, it was a great series, and there was some great baseball. I happened to be working that night in the trauma center, and I have to say, people were there was huge celebrations. Everyone was like, "Oh yeah, go Giants!" And then there was a kind of a collective, "Oh no," because this is what happened later. There was you could hear the bells going off. You could see the smoke, and somewhat predictably, there was a lot of mayhem. This is some photos from the Mission District. A lot of these made kind of the national press, but there was a lot of misbehaving going on that evening. The typical history of our patients in the trauma center that night was, I was super drunk, I was jumping over a fire, and then someone shot me. So I kid you not. It was sort of those are the common components of a lot of our patient care that evening. And we also knew that after that night of celebration, we managed to kind of deal with the issues that night, but we knew we also had 3 days before we were going to have a celebration. We were going to have a Giants victory parade and then a huge celebration at the Civic Center in front of City Hall. So we had a couple days to kind of get our EAP together, and I want to sort of impress on you a couple points that we learned from this experience. Let me just move on to the next slide here. There are 4 points I want to bring up, and they're all sort of the 4 Ps. They're prevention, using event professionals, knowing your patients, and then optimizing your process. So first on the prevention front, this is another photo of kind of the world's worst Giants fan. This is a man named Tyler Granis who was caught in a beautiful chronicle photograph involved in some of the worst parts of the celebrations on that night on the 28th that later on resulted in a vehicle fire and complete loss of that. He was thankfully apprehended and pled guilty to the charge. Pled not guilty to this charge, which was a bit dumbfounding given the photographic evidence of all of this. But nonetheless, my first point is prevention. You got to recognize that in this time and age of instant communication, cell phone cameras, everyone is being recorded constantly. This is true of Boston. This was true in our more recent experience with Asiana 214. This was definitely true during some of the events of last October as well. And because of that, we need to be able to use this to our benefit. So media and being able to prevent any surges in medical needs or any impending disasters. If you can do that, it's really helpful. So getting a consistent message, whether that be through the mayor's office, police department, your own fire departments, we were able to do this, and the message was really clear. San Franciscans, keep it classy or go to jail, was sort of what was said. So this is the parade route that was on our event action plan. It was a recreation of the 1958 historical parade down Market Street and then a right turn into the Civic Center Plaza. And then all of the celebration and the players would then come right in front of City Hall and party for who knew how long. It also happened to be Halloween, all right? So kind of a convergence. It's Halloween in San Francisco with Giants victory. What could go wrong, right? So that was the plan. And let me show you some other details of the plan here. This is an aerial view of our Civic Center Plaza. The red bars were our entry and egress points. There were some kind of blue boxes that show some of the ground assets and foot teams. In the lower left-hand corner was our alternate care site, and that's kind of what I want to focus more so on this talk about. We had a field clinic that was set up with some very specific protocols for medical care. And then we also, you can see just below that lower left-hand gray box, we had an ambulance strike team that was available to transport patients off of scene and to the area hospitals if necessary. All right, so the projection was that about 1 million people were going to show up. It turned out that it was a little bit more than that. As you can see there, it was literally extremity to orifice, as we like to say. And when you couldn't pack them in any closer, they went up. Here's again more of the crowd, and we were going 3 and 4 deep. We had probably 1.1 million people in this just a couple block area for several hours. So let me talk about our alternate care site. We had some specific objectives for alternate care site, and they really were to offload the system volume that we expected to see from this. We also were hoping to provide some care for some of the minor injuries that were associated with this, just treat them and street them, prevent the need to suck up EMS system resources, and then also do transports and care throughout this huge mess of people. And then, this is again back in October, before many of the more recent event disasters, we designed this to have surge capacity in case there was something that really, truly bad happened as an MCI. This is a schematic of our flow chart. We had sort of the classic bottleneck of triage where everyone would come through, and we had the area divided into three sections. A minor medical area, then we had a larger sobering area, and this is very important and was very heavily used. And these were areas that, in the sobering area, there was each spot had a mat, a bucket, and a volunteer, okay? 3 critical components of that type of care. Further, we had an acute care and procedure area with kind of a private exam and bed area. So if we had people who happened to be sicker, we could bring them back there, do minor procedures, and if they really needed to go, we would then use that area to move them rapidly with our transport officer and office scene. So this brings me to lesson number 2. Event professionals. So event medicine, I think Dr. Pepe may have some comments about this, but this is a very specific type of practice with very specific considerations and needs. And I highly, highly, highly recommend you that if you're going into an incident like this, use all the resources you can, find the specialists you can. We were very lucky to work with a group called RockMed that's based out of the Haight-Ashbury Free Clinics. They are consummate event and concert specialists. They do 400 or more concerts a year. They do everything from the Jonas Brothers to Marilyn Manson and some other music that I'm not cool enough to know about, but they really do it all, and they're used to dealing with a sort of mass gathering type of medicine. Their philosophy is here. They're a very old organization. They kind of grew out of a lot of the Grateful Dead concerts in the San Francisco Bay Area, but they really focus on taking care of people at the scene, getting them back to their families, and trying not to get them involved in law enforcement, okay? Because obviously there are a lot of other illicit activities that are occurring at that time. So I've heard. Another thing is now that you have your team together, you're thinking about the types of plans and contingencies, what kind of patients might you have in this? All right, so anticipate the types of conditions that you may be taking care of. No surprise, we were having a lot of agitated, intoxicated patients, right? From any time of, on Halloween, you're going to get 1.1 million people together. I'm sure for many other events in the past and in the future, you're going to see large masses of patients like this. And how you deal with them in your pre-hospital phase is going to really depend, that's going to determine what your success is in managing the overall system, okay? A couple quick tips that we learned a lot about. We experienced a lot of people with the so-called intense psychedelic reaction, or IPR. These are people who are really literally having the worst trip of their lives, okay? Many of you may have experience with this professionally, obviously, of course, but these are people that require a lot of care for their own safety, for the safety of the personnel, and then just getting them to definitive care. We also had people who had acute crowd syndromes, and you get 1 million people together, you put a person in the center of that, it gets a little uncomfortable, and people were having anxiety, shortness of breath, palpitations, and sometimes they just needed a little bit of a timeout. So we rehearsed timeout areas. We had some quiet takedown areas that were not too disruptive for people who were having their IPRs. And then we also defined some very clear criteria for transport off a scene. So these are the types of patients that we saw. Again, a little bit left shifted from our normal 911 population. Median age was 22. Relatively even mix of men and women. Sort of surprisingly to me, I thought that there would be a much higher male predominance, but not so much. The types of conditions that we were seeing, again, there was a lot of alcohol and other drug intoxication. But you notice there actually was some other types of typical 911 calls in here. So that's another consideration, is that you have to be prepared to deal with absorbing the area's 911 volume that may just bleed into your event. From that, we took care of around 120 or so patients from both the alternate care site and area first aid stations, transported a dozen to EDs, and then we used a sobering center van to move another 4 to our sobering center. This is all within about a 6-hour operational period. So it was pretty busy. We were definitely humming along there. But I believe the operations of the ACS were able to offload the overall 911 system. We were able to provide on-site care for a lot of people. And should the contingency have been invoked and we had to sort of surge up as a real MCI unit, I think we would have been able to do so. So finally, my last point is about the process. As you're planning these types of events, make sure that you talk about some of the scenarios. And the ones that we found that were very helpful were the acute medical care patient, somebody who may have, for example, an ST elevation MI or an acute stroke, somebody who you need to rapidly stabilize, do some initial treatment, and then move them off of scene. The other one, which we did several times that day, was your intense psychedelic reaction. Figuring out how you're going to talk that person down if you can, sedate them if necessary, get security involved, and then just have a quiet area to kind of take care of those people. That was an important kind of choreographed care piece. And then finally, make sure that you have your entry and egress plans well laid out, as in any event, and as well as your demobilization plan. Everything must end, and it's important that you end this well. So on that note, I will end this presentation and ask if you have any questions. I'm certainly open if there's any feedback from your experience, Tom. Yeah, thank you. Yes. So, yeah, so good question. So modeling, that's very interesting. I'd love to hear more about that, because what we found when we were planning this is that there really was not a lot of good modeling. We could use larger scale music events and types of festivals that we had, and the best prediction that we had for this event was the celebration from 2010. For the Giants as well, which was in a similar sort of fashion. But we actually had far fewer patients than in that case. And I think that was due to a number of factors, more about the parade route. During 2010, we had some traumatic injuries along the parade route from people falling off of structures. And I think that the planning of the 2012 event actually took some of those things into consideration, and they shortened the route and then moved to a central area because of that. So. But that's really interesting. I mean, did you find that your modeling was accurate?
No, and for the better.
Okay.
And I'm not even sure what the model is. Our emergency planner he used. It's a computer program. He entered the statistics and everything, the weather temperature. For us, it was a big deal because it was the middle of July and the temperatures were 102 with the relative humidity 100%. The number of patients we saw were about the same, but what we were happy about were the fatalities. They predicted with the weather we'd have probably 4 fatalities. Wow. Even one of them being a horse, because they had all the animals and stuff there. And luckily, we didn't have any of that. So. Yeah.
Wow. I think that's we always kind of talk about the outcomes of some of these management plans, and we say, wow, we just got lucky. One of the things I would say is that there's luck, and we all are thankful for being lucky, but I think there's also mitigation of risks. And we shouldn't all chalk it up just to complete luck. If you have a good plan and it's working, you're going to be pleasantly surprised.
Yeah, that's why I was curious. We think a lot of ours had to do with the aggressive cooling things that we did, cooling tents and things like that.
I certainly did. Yeah, that's good. And that's what the planning is for, I'd argue. Yes, and back.
Yes, doctor, I just have one question, and if I missed it, I apologize. I know you said you had resting areas for people that were intoxicated. You had a van that brought them to a certain area. Was there a doctor on scene to make that determination that they were okay to stay there? In other words, I'm looking at a liability factor.
Yep. Yeah, absolutely. So good question. We had several physicians there. I was on site at the alternate care site. We also, RockMed staffed, I believe, 2 or 3 physicians at any given time. The sobering center that we transport people to is the same sobering center that our city uses, where there's a nurse on site. And we use the same criteria that we always use during our normal 911 operations to accept and monitor those patients.
So you have a sobering center in the city that, because I mean, obviously I think it's a problem everywhere, and obviously where I'm from, public intoxication.
Yes.
But we always end up taking them to the emergency room. They don't seem to arrest them where I'm from.
Yeah, so I'd be happy to share with some of those criteria with you that we use in our city, but they're pretty well defined. People have to have relatively normal vital signs. They have to have no signs of head trauma. You have to have a reasonable fingerstick blood glucose.
Right.
They have to be able to give some basic information, and they also have to be on there's a refusal list. People that get banned from the sobering center, they can't go there. I know.
Yeah, if you could at some point today,
I'd be happy to, but yeah, it's a very good question. I mean, it's from a system standpoint, it's risky to have these unless you have some pretty clear
Right. Well,
definitions.
I know it's really taxing the emergency rooms where we're from. It's taxing us, the rescues. I mean, it's a major problem. I'm sure it's a problem everywhere.
Yeah.
But to my knowledge, we don't have any sobering centers that, these people don't have to go to the emergency room, that they could be taken somewhere else.
Yeah, I mean, I think there are a lot of really good models for programs like that, here in Denver as well as many other places. But I'd be happy to share our San Francisco experience.
If you're not careful, you'll end up in the Denver Cares van out tonight. Got a question over there.
Oh, yes.
Quick question, Doc. Did you have any, if you were going to apply that ACS model to a extended, week-long event, is there any suggestions or lessons that you guys learned that you would alter?
Yes, actually, that's very interesting you asked that. We're currently in San Francisco hosting the America's Cup, which is not just 1 week. It's quite a long time, and we've been having we've had an on-site alternate care site similar to this, but actually much more pared down. We are partnering with one of our local hospitals in the Kaiser Permanente system to staff that. And I guess the key things about that, I would say, would be the definitions of long-term protocols for staffing and interaction with the EMS system. Because this day, we were able to say, yes, from this time to this time, we have EMS 911 operations and we have event operations. If you're doing that for an extended amount of time, whether it be a week or a month, you kind of need to make some other contingencies. And I think that's kind of one of the challenges of running something like we are with America's Cup or later. Do you have a specific event in mind, or do you?
Yeah, we have the Waste Management Open in Scottsdale and we deal with a lot of the intoxication stuff and just large-scale event. But it runs for 4 or 5 days. So.
Yeah. One of the things I'll share as a tidbit from America's Cup we've learned so far is that predictions about what your turnout is going to be and your potential injuries and need can be very, very inaccurate. And so you need to have some contingencies to be able to flex up and, as in our case, actually flex down, because the turnouts for our the crowd size for America's Cup events has been much lower, and the associated injuries and need has been much less. Thank goodness. Yeah.
I think, Dr. Pepe, we want to keep things on track, correct?
Thank you all.
We've got time at the end for other questions, so.
Well, I have a couple questions also. I mean, how are the Giants going to do this year? Are they going to be back into the World Series? Because the Rockies definitely are. So we may meet you and have to face the same thing. They do.
I was telling Dr. Pepe, actually, my family are hardcore Boston Red Sox fans. So
They actually might make it.
yeah, so I have to go with the Sox.
So we're gonna talk a little bit about now some of the lessons learned from Colorado shootings, and I want to open up a couple things. First of all, there were a lot of people at these events. My personal involvement was I was there as part of the scene at Columbine. I was there at the scene for Safeway, and then I was at the hospital for the Aurora shootings. There were a lot of people in all of those areas, and there's a lot of perspectives, and what I'm going to talk about today is mine. I will open up by saying that I thought from the standpoint of Littleton Fire, Aurora Fire, who were the two primary agencies on on Columbine and the Aurora shootings, did an outstanding job. What I want to do here is try to just focus on a couple of lessons that, again, from my perspective, can be taken away from these. And it was remarkable to me how much overlap there was from things that, at least from my impression at the scene and my impression in the hospital at three different events, overlapped dramatically in terms of the lessons that were learned in both spots were very similar. Also, when you listen to folks that were at other events across the country, and we've talked about a few of those as well, a couple of common themes keep coming up in terms of lessons learned taken away from events like this. So I tried to focus a couple of things that we're going to talk about in the next 10 minutes on what seem to be common themes over and over again and my perspective of how they applied to these particular areas. I'm in a little bit of a unique situation here because I've given a presentation on these a number of times, but there's usually not other people that were actually there in the audience. Today we have one. And in fact, I think you may be in a couple of my pictures. So prepare ahead of time for that. EMS Chief from Littleton is here that can certainly would be a great opportunity to get perspective as well and see if there was a lot of overlap there. Well, okay, fair enough. Okay, so very quickly, we talked about this earlier. This is Denver General. This was our Denver General in 1977. We have the same ambulances today. Can you believe that? This is just after we started using hearses. No, actually, this is today's Denver Health Emergency Department. Same spot, a little different look to it. But I put this picture up there just to remind us. This is the ruins of San Francisco in 1906, the best picture I could come up with from 1906. It just reminds us that there have been events that have brought about disasters, potential for disasters, mass casualty events since human beings have been in existence. But I don't think it is hard to argue that there are more events now than ever that potentially involve us and potentially involve mass casualty disaster situations. If you want to go more recently, there's this. I can almost always, if I give a talk like this, look back the last 3 or 4 weeks and bring up an event of some sort that if it didn't actually involve mass casualties, at least had the potential to involve mass casualties. The point is, if we haven't already been involved in it, we will be. Everybody in this room, everybody involved in EMS is going to be and needs to be ready to be involved in an event like what we have been talking about and what we're going to talk about here. So I think we've gotten better at this, particularly from an EMS fire standpoint, but let's just go ahead and say it. Let's not talk about if, let's talk about when and how. So with that in mind, we go forward. This is school shootings, if you want to take just an example of some of those. And here for Colorado, we had certainly the Columbine shootings, the Safeway shootings in 2006, and then the Aurora shootings that everybody heard about as well, just a year ago, this July 20th. And how about this last Wednesday? Just get anybody's heart rate up just a little bit. Bus crash, all kids, 38 kids and a driver. 4 were critical, 2 were serious. Everybody's got neck pain. I got that phone call that morning. They're all coming to you. Now, thankfully, the initial call was that they were all hemophiliacs. They were not. None of them were, thankfully. But even then, this gets, I think, all of our heart rates up a little bit, both as the responding agencies and as the receiving hospital. And no matter where you are, no matter what situation you're dealing with, even if you can't imagine a plane going into a World Trade Center or a shooting at a school or something along those lines, you can certainly imagine a school bus. And you can certainly imagine something, the kind of impact it would have on your community if something like this were to happen. And this is a potential any day event. Louis Pasteur reminded us, chance favors the prepared mind. We do have to be prepared. How do we do that? So the first thing we do is we just define what's a disaster. And I would argue that a disaster is not the same in any of the agencies that we represent here today. A disaster represents any situation that overwhelms our community's ability to respond to that disaster. So if I take one area where a rollover accident and 4 critical victims is absolutely a disaster and overwhelms their ability, their resources to respond to that, whereas that might be a typical Friday night or even a Tuesday night for some of us. So first and foremost, what does overwhelm your resources? At what point do you need to start thinking about where you're going to get those additional resources? Mutual aid, all of those things, we have that. How do we go beyond that? And do we have those in place in a way that we can really access them quickly? And then from a disaster management standpoint, here's the mindset for each of us, because it's very different when we're dealing with something like this than we do with any other event in our lives. Can you change from priority 4 to access 2? I'd argue we never do that, right? What do? We encounter a patient, we give them every resource we have available to us to stabilize that patient, and only when that patient has been taken care of do we move on to the next one. And here's a situation where you cannot do that. Are you ready to ration care? And this is a transition in mindset that many of us are perhaps ready to welcome. But it is a transition, and make no mistake about it. It's something different from what we do every day. So a couple of quick comments in terms of the lessons learned. This was a diversion device from the Columbine situation. This was a diversion device. This is in Aurora. You know, he set up where he put the music on really loud in the department near midnight, trying to generate a complaint that once they got there, pound on the door, no answer. Eventually, with that loud music going on, you break down the door. What was going to happen when they broke down the door? That the idea to bring not only to initially harm the responders, but to bring the response in that direction when the event was going to go on from the same responding area in another direction. They're thinking about this. You look at events across the country, they're looking at this. They're targeting us. We know scene safety better than anybody. We have to do scene safety as well as we ever have, because anybody who's thinking in this mindset is going to think, how can I target us, the responders? For communication, we need to think about that in advance. Obviously, different agencies on different frequencies doesn't work. We've made some advances with that in Colorado over time. We're still not perfect. When we drill, are we really drilling to the point where we're testing those communication processes? Appropriate and necessary communication, cell phones. I still read a number of emergency response plans that involve cell phones. What's the first thing that happens at an event like this? At midnight on a Thursday night, much less noon on a Tuesday. So people get as close as they possibly can to it, they whip out their cell phones and they start talking. And so over and over again, you see situations where the cell phone networks are overwhelmed and your cell phone is useless. If you are depending on that, what do we do every day when we communicate? If you're depending on that, that's going to fall apart very quickly. Temptation. To rush in and treat. Is that scene safe? Anybody familiar with that picture? You know where that comes from? It's an AP picture that was the AP published that out of Oklahoma City. And about 2 minutes after that picture was taken, the 2 nurses on the left were killed walking into an environment that collapsed on them. What good have we done by becoming victims ourselves? This comes up over and over and over again. Where are our efforts needed most? It may not be that first patient that we see down that needs our efforts the most. Remember, it's a change in mindset. It's the good of the many over the good of the few, and we don't ever have to think that way, so it's hard to make that transition. The other temptation that we run into over and over and over again, rush and transport. And this is where we need to be better, because each time you look at the hospitals, when they respond or have dealt with an event like this, they say the same thing. The closest hospital was overwhelmed almost immediately. Where do the initial ambulances go? Where do the initial patients from the scene go? And the first call I got, and when I arrived at Columbine, was my closest hospital was closed. Can't take any more. It's a very similar thing happened in Aurora. This is where we can be better. You talked about what perhaps physicians can do, what perhaps we talked about alternative care opportunities here. This is a perfect example. If you've got 20 hospitals to distribute to, you're probably going to be okay. What if you have 1 or 2 and you've got 50 victims? If you just bring all those victims to that hospital, I would argue you haven't done any good for anybody, because now you've just transplanted the disaster from the scene to the hospital. What about setting up alternate care sites where with 1 paramedic, maybe a nurse or another healthcare provider, I can manage 30 patients if I have to with some relatively open protocols and a little bit of time. Something that might normally be a lights and sirens return with a bone sticking out of their arm could be very easily managed for a period of time at a community center or a high school or something along those lines, while the ones that are truly dying can be managed at a hospital and give them a chance to recover and be able to manage this. We need to be better at this. Simply transplanting the disaster is not going to help anybody. The other temptation we talked about a little bit as well, you addressed it. The rest of the city doesn't stop. They're still having their strokes and heart attacks and car accidents and all those types of things in the middle of an event like this, even if it's midnight on a Thursday. So you can't apply every resource you've got to this and forget about the rest of the city. How are you going to distribute that evenly and keep that going? Organization, from the scene standpoint, absolutely everybody will arrive. I realize it doesn't show up very well with the black background, but that's our exit out in Columbine for ambulances, egress and ingress initially. This is the emergency department. Everybody's there. Staging is to be critical. Vehicles are everywhere. Crowds are everywhere. It was remarkable to me how similar this was in the emergency department. I had been, by the time of the Aurora shootings, I'd been in our emergency department 15 years. And there was stuff that was showing up in our emergency department that night that I had never seen before. People and things showing up. That is remarkable. And we had, again, at midnight on Thursday night, we had hundreds of people showing up for what turned out to be 10 patients. So this will happen. How are we going to stage? And emergency departments have to do the same thing as we do at the scene. This was the ambulance bay at the University Hospital during the Aurora shootings. You may ask, where are the ambulances? Most of the patients didn't get transported by ambulance in this one, in part because of the staging issues at the scene. And then here, they just showed up. The actually sickest patient in this group is out there in that far police vehicle, and there is an ambulance trying to get in. Staging is a big deal at events like this. It's not just us. This was the first bombing in New York City at the World Trade Center. There's a critical patient in this ambulance right there. Couldn't move for 45 minutes because there's too many vehicles there. I love our law enforcement folks, but they're the worst at it. Everybody shows up, they get as close as they possibly can, they get out of their vehicles, and they lock the doors, and they take off. And we got all these law enforcement vehicles all over the place. It happened again at Aurora. And you may not always know, I think you're in this picture, but you may not always know what you're going to do with all the things that show up, either at the hospital or at the scene, but you might want to know they're there. This guy, literally, that guy in the front stopped by in 1 second, turned over and said, "Hey, Doc, where do you want me?" I don't know what that thing does. I'm not sure what I was half tempted to say, just go in the school, see what happens there. Identification of the scene, very clearly an issue. We've been better about this in pre-hospital than we are in the hospital. I would argue we got to do it just as well in the hospital. It's these things, these vests that you can leave anywhere, anytime, because nobody in their right mind would ever steal them, because they're obnoxious and they're awful. But you can see them for anywhere and identify who you need, who the key players are, and how you can get a hold of them very quickly. There were, not only at each one of these scenes, but at hospitals as well, people all over that were not identified, that nobody could figure out who they were, and it was confusing for everybody involved. This was, and again, I think that is you in the background there, but this is one of the training chiefs wearing clothing that could have been mistaken by a sniper, and in one case may have been, for clothing that was on the shooters. How do we know to prevent this? Clear identification at the scene, at the hospital. I want to talk a little bit about resources, because we were pretty good at resources for victims and providers. We could be better. What about pediatrics? That bus that rolled over with 38 kids, do we have the resources, the equipment to take care of 38 kids? Thank God we don't have immobilization, because we're not going to mobilize them anyway, right? But do we have the equipment for them? If not, where are we going to get it? Here's another argument I would make. What about for families? This has come up at each one of these events as well. You're going to separate families? We have the wonderful asset of Children's Hospital here. The problem is, I've got a 13, 10, and 6-year-old at home. If I'm in an event like this, and we are critically injured, fair enough, all bets are off. But in most cases, that's not what happens. Not everybody, or not anybody in the family is critically injured. You want to separate me from my children? It's not going to happen. And so how are we going to do this? How are we going to allow for families to stay together, which can sometimes be one of the most critical things we do at an event like this, and still manage them? Have we thought about that? Call down, I just want to emphasize how important it is, because no matter how you respond, hospitals, medical services across the city are going to shut down and do everything they can to apply to this area. The sooner we can tell them to go back to normal operations, the better our community will be. So we have to do the call down at the same time. I'm going to make a note from myself, and I've heard many people say this before. The media response to this was more overwhelming than any of the events by themselves at all. They were everywhere. They were at the scene. They were at the hospital. They snuck into our OR in one case during the Columbine event. They were sneaking into inpatients, or not sneaking in, just walking into inpatient units. They were everywhere. They were calling at 4 o'clock in the morning. Their response was overwhelming. I wasn't personally prepared for this. We need to be better prepared for how to manage this. We need to have people, fire departments have been way ahead of the game on this one, but we need to have people that are experts at dealing with the media, use them for the benefits they can be, know how to manage the fact that they can overwhelm the situation as much as anything. You will have opportunities that will come in response to events like this. Are we ready for that? You'll have a voice. It's time to use it. I didn't get the chance to talk to him about our healthcare policy. I wanted to. But there are opportunities that have come up with our local government and even our state and to some degree the federal government as well, that you now will have opportunity to be involved with and have a voice in. In terms of the aftermath, I'll just throw in a key plug for a critical incident stress debriefing. There are other ways to do this. Have a method. Take care of your own. Involve the people in your agencies that were involved in the event and that were not, spouses as well. They're the ones that are going to recognize the impact that it's going to have on your people. And please don't underestimate the impact it will have. It will impact everybody. And sometimes it'll take weeks or months. And in our case, it was maybe years. But it will be an impact. Lastly, inevitably somebody asked, why Colorado? You guys have had your share of bad luck. I don't have an answer for that. But what I do have is this. When you plot off our access to guns and our access to psychiatric care, and it looks like that, what do we expect? This is a crisis in our country. It's a crisis that impacts every single one of us. Until we hit this, until we address this, we will continue to have events like this, I am convinced, and it will get worse. It will get worse. Finally, it will happen to us. Are we ready? And are we ready for some of the things that we don't always think about when we prepare for events like this? Beware of the second hit. They're coming after us. They're coming after you as responders. Are you ready for that? Have a plan. Use it. And drill it in a meaningful fashion. The drills that we had before Columbine, and even to some extent before Aurora, were quite honestly, in many cases, didn't really push us. They were the kind of ones we wanted to get through, check off, and say, we've done the drills. Use those. Use them to really push yourselves. That's where you get better. Communication and cooperation are always going to be the keys. And with that, I will finish up. And thank you again for your attention. Hopefully, there was some points there that we can all take away. I would love, really quick, any insights from your standpoint, being at the scene?
I think the biggest one that you really covered for me, the biggest one you covered is secondary devices. And there was 2 cars outside in the parking lots that the only reason they didn't kill a bunch of firefighters and police officers because they didn't understand how a clock works. But besides, yeah, and so you really, I mean, that's really changed our way. We never park in front of a dumpster. We never do any of that. You got to really be understanding that. And when this new program's coming about sending medics in right away, I think it's the training needs to be with the police officers so they understand, is there chemical, are there secondary devices, all that's going on before we make that entry into the warm zone. And I think that's going to be critical.
And we get slapped in the face with this many times. When we took down, Mile High Stadium, where the Broncos used to play, when it was taken down, we did a big drill, take advantage of that opportunity, and we put a Ryder truck in front of this. And this was 3 years after Oklahoma City. So you got to think, somebody's going to notice it, because there were no other vehicles around. They had closed the area, got everything. The only thing there was a big yellow Ryder truck. And we went through this drill, and everybody went right by it, and you actually set up a station right next to it. And nobody ever paid attention to it. And how much we are leaving ourselves open for stuff like that. Dr. Pierce, you ready? Very good.
Career in EMS for years, actually starting
just forwarded that back.
Got it. Thanks, Paul. All right, now I'm gonna pause for a moment because this is the finance talk, so I'm gonna give you a moment to get at your cell phones, to call your friends, and tell them to hurry on down because this is the budget conversation. So this is the one that's most exciting. Thanks for the topic, Paul. Appreciate it. But let's face it, we had some good talk this morning about where EMS is going, and the days of just being the ambulance goes out and picks up somebody and takes them to the hospital and bring them back. It's becoming more complicated. EMS is maturing quite rapidly in a very dynamic time in healthcare change as well. And so, with the fire service, I think that, to some degree, this whole conference, we're sort of preaching to the choir. And at lunch, I sat with some of our firefighters from Houston, and we were sort of lamenting on how within the fire service, it seems that there's some people who get it, that EMS is important to the fire service, and we have to be able to roll with the changes that are coming. And then there are some folks within the fire service who seem to be pretty resistant to change. And that's a problem. And I suspect I'm talking to those folks here who kind of get it. But at the end of the day, when push comes to shove, the naysayers are going to be able to break our knuckles over the budget. And if they don't want something to happen, if they can find a budget reason for it not to happen, then at the next level up, whether it be your city council, your county commissioners, or whatever, that's going to be a real uphill battle. So your medical director can help with that. And what I'm going to go through, some of the stuff I'm going to go through, we actually already talked about today, so some of my colleagues have already stolen a part of my talk, but that's okay, because they're a good bunch. But it's budget in, budget out, right? Right? You've all been through budget. Anybody here not participated in budget development? Okay, one person. God love you. But so at the end of the day, it's like being on a diet. Calories in, calories out. Same thing with the budget. There's a finite number of dollars that we think we're going to have next year, and based on what we think we're going to have, we get to plan on how we think we're going to spend it. And depending on the political environment you're in, you either have to stick really close to the budget that you projected, or there may be some play in it, but there's rarely a lot of play. And one of the reasons to keep in mind why there's never a lot of play is that, like in my organization, about 95, 97% of the budget is salaries. So we may have this huge budget, and for the Houston Fire Department, it's somewhere like $480 million, and it sounds like an obscene amount of money. At the end of the day, we're looking at 4% of it for administration, other than salaries, and for projects and things. So a lot of it is salary, or maybe salary and supplies, I think. But there's very little wiggle room. So you got to be smart about what you're going to spend your money on. And so we think about setting up the budget and how much are we going to spend next year. And when you approach it with that attitude, you've forgotten half the equation. You've forgotten the revenue side. And now, anybody in here not charged for your ambulance services? Okay, one. Okay, most folks charge for your ambulance. How many people in here charge really well and are really efficient at it? One, two, a couple think. Okay, so most of us are not very good at this, and it's because it's a complex situation. I'm going to get into this a little bit more in a moment here, but the revenue side is a complex thing. There are people who spend their whole careers perfecting it, and then there's the expenditure side, and that's what I was sort of talking about that we're always sort of thinking about. And for the medical director's thing, and I'll get, really the bottom line question is it worth, the big word there being, is it worth the expense? So let's look a little bit more on the medical side. So medical billing, there are whole companies, and maybe some of your organizations contract with a medical billing organization. I know that we do. Well, let me put it this way. We contract with a billing entity, which is different from a medical billing entity. And that's one of the mistakes that you can make. And that's one of the mistakes that I think that we made in Houston, is that we've contracted with somebody who did municipal billing. They do a lot of billing for governmental agencies. So you think about all kinds of things. There's all kinds of contracts that the city provides this, that, or the other to the community for which there's a fee, and they're used to that. That is completely different from medical billing. Medical billing is completely different from that. And so you need to advise your civic leaders that when you're talking about ambulance billing, if you're going to contract that out, which may be a smart thing to do because it's so complex, don't just contract it out to somebody billing. Contract it out to somebody who maybe does it like for some of your local hospitals, or if you've got some large physician groups, because they've learned how not to leave a lot of money on the table. And I think that that's what we in EMS do a lot, is that we leave a lot of money on the table. So, like I said, it's extremely complicated. And the rules are different whether you're billing a Medicaid patient or a Medicare patient. And who's here from California? Or Medi-Cal, right? Medi-Cal is yet a whole different thing, and that's particular to California. Then the private insurance. How many different kinds of private insurances are there out there? And you know what? Each one of those insurance companies has a slightly different way of doing it. And if you're just sending them a generic bill, you're going to get a generic no in response, because they all want to be billed in a particular way. And if you don't play by those rules, you don't get paid. Then there's workers' comp for your own employees. And now that's a different one, because we want to really make sure that our employees get their workers' comp benefits, right? Well, you know what? Yes and no. There are people within the government, for example, your fire chiefs, they're going to want to make sure that your firefighters get all their workers' comp benefits. I hate to tell you, there's somebody in the city's finance department who wouldn't mind it if maybe they didn't get it, because that actually winds up costing the city to pay that firefighter's workers' comp benefit. Did you know that? You know that somewhere inside there's actually the enemy is within us sometimes? They're not really the enemy, that's an overstatement, but my point is, and I shouldn't paint them that way, but my point is that if your employees get all their workers' comp benefits, that means it costs that much more, and sometimes there's some not so benign neglect that occurs. Somebody needs to be looking out for that. Especially, back to workers' comp, especially if your accounting is such that in Chicago, the payment for your firefighters' injuries comes out of the fire department's budget, right? So you want to make sure that you maximally recover that to offset that expense in your budget. Now, within the city, it may not make any difference at all when you look at the total wash at the end of the year. But then when you go to start battling to get dollars, and they look at, man, your workers' comp costs are way worse than public works, you take a political punch in the nose on that. And if some of that can be offset, you need to make sure as much of that gets offset as possible. And most of us in city governments are completely clueless to all this stuff. Now, your physician, your medical directors, depending on the situation, quite honestly, I'm not great at it because I'm full-time. But Chris here, well, you work for another governmental agency even when you're working clinically, right? Okay. But your medical director may work, depending on who your medical director is, they may work in the private sector. And I'll tell you what, your medical director works in the private sector, they know this stuff. They know this stuff cold. They know a lot of the tricks. So lean on them. They'll help out. At the end of the day, it's documentation, documentation, documentation. Because even if you've got a good billing company, if your firefighters are not supplying them with the right information, they can't generate a good bill. Now, that having been said, do we make it easy for our firefighters to do that? Or do we make it onerous and difficult for them so they find shortcuts to get back to the station quickly? Again, now you need somebody who understands both the medical billing side and the environment of the firefighter, right? And then finally, QA, making sure that they keep up on it. And this isn't about this last part. You gotta be careful. This, again, is where your medical director can help. Because this isn't about getting Bob in trouble because he wrote a lousy record. This is finding out, why does Bob write a lousy record? Because if Bob's writing a lousy record, so are Tom, Dick, and Harry, and they're not bad guys. They didn't come to work today deciding to write screwy records. We just didn't make it easy for them to do it right. All right, how many of you got this on your units? How many of you got one of those? We talked about those earlier today. Anybody got that? And who's got this? Okay. It's the geyser squeezer. It is the geyser squeezer. These are not cheap. Do your folks enjoy having them? Okay. Do they believe they make a difference? Okay. If you didn't think they made a difference, you wouldn't have them, right? Right? Okay. but they're not cheap. So when you go to council, or you go to your county commissioners, or you go to however it is that it's run, and you want to get one of these expensive devices, you've got to be able to justify it. Now, like with the last two, the geezer squeezers that are out there, there's a couple of different arguments you can make. One is that, you know, they help save lives. Well, okay, is that necessarily so? Because there's some debate about that. Well, they prevent back injuries, and so they help on our workers' comp costs. Well, is that necessarily so? And where's the data for that? And so sometimes with workers' comp things, you guys can, you know, you can sort through that on your own. And these medical things where you got to go to some of these journals, like there's 3 piles of journals back there, journal articles, and Paul and some of the other presenters were talking today. Have you read some of those? Are they easy to read? Would your council member or your mayor, your county commissioner be able to read one of those articles and get through it and understand what it says? No, but your medical director can. Your medical director can take that scientific mumbo-jumbo and translate it into something that somebody who's going to say yes or no on your budget. So lean on them, get them to help out. Because maybe these things you do want, you do need, they are good, but you're going to have to justify them. And then the expenditure side, this is kind of what I'm getting at. So what is the science behind them? What is the real value? Now, value that's an interesting word, isn't it? What is the value of these? Can you bill for some of those things that we showed? Do you bill for them? Well, the answer is yeah, you can bill for anything you want. The question is, do you bill for them, and how do you justify the billing? And in some of those entities that will reimburse, like some of the private insurance companies, they will, if you itemize some of these things, some of them will pay for the use of certain medications or certain disposable pieces of equipment. Some of them will pay for it, others won't. Medicaid tend to not pay for a lot of itemized stuff, right? But some of the private insurance companies will. But you got to bill for them first. You got to put that in there. All right. Oops, is that it? I guess that was it. I thought I had one more slide. Maybe not. But it was just a picture. But here's the bottom line, and this is not a terribly complicated thing, is that when your fire chief, and I've done this, when we've gone to the mayor, in the way in my city, the way it works, is we go to the mayor, we say, here's the budget. This is what we want to do. And then the mayor says, okay, I like this, I like that, maybe I want to tweak this. We have this conversation. And then we got to go and we got to get it approved by city council, okay? So with some of these items that we have that are expensive, or, and I will tell you that currently right now, the city of Houston, with our billing entity, we just divorced them because we decided they were doing a lousy job. Well, I shouldn't say that. This is being taped. This is the talk why the cameras are here, because everybody wants to see this. This will be on YouTube, I'm sure, with millions of hits. But we decided that we weren't happy with the job that our former billing company was doing. And so we're moving to somebody new. But I will tell you, as the medical director, I have been heavily involved for a number of years in trying to get light onto the problem of the old billing company, and that they probably were leaving money on the table. And they were probably leaving lots of money on the table. And we now believe, to the point where we've now gotten rid of them, that yeah, we believe that they were leaving lots of money on the table, and that there was probably some billing practices that weren't, I got to choose my words carefully here, that weren't optimal for both parties. But I'll tell you what, this is one of those things where it's going to fly under the radar unless you've got somebody looking at it. And the language of this billing is not commonplace. So get your medical director, especially if you have a medical director who's in the private sector, because I'll tell you what, they know this stuff pretty well. And they're going to be able to smell when you're leaving money on the table. So at the end of the year, when it comes to you wanting to buy new, and like with HFD, with Houston Fire, we want to buy a new ladder truck, they're going to look at, well, the fire department is not a money-generating department, right? But if we're doing pretty good on our ambulance billing, because we know what we think it costs to provide EMS to the community, and we're never going to get 100%. We're never going to be break even. But if we're covering 20% of our costs, that looks pretty bad. If we're covering 60% of our costs, and they know that the national average is something less than that, that gives us a lot of credibility when we want to get a whole bunch more money to buy a ladder truck, because it washes over. Because a lot of times politicians, they say EMS and the fire service, they see it as two separate things in one house, and sometimes they see it as all one thing. And sometimes you leverage that one way to help you, and sometimes you leverage it the other way to help you. But I would say that billing is a two-sided equation. It is not simple. We do a lousy job, at least I will say in my shop, we do a lousy job. We're trying to do better with our documentation, but it doesn't really matter a whole lot if our billing company isn't doing the part that they're supposed to be doing. And so, so we're going to a new company, and actually what we've done is we've split the contract so that the billing company is just doing billing, and the patient care record, electronic patient care record, we have a separate contract with. They were together before. And that's probably another mistake, because at the end of the day, your firefighter is getting service not from the billing company, but from the electronic patient care records. That's where they interface. And so if you want to have something change in your electronic patient care record, and you got to go through the billing company to get to the people to change that, you just built a roadblock into your own system. So as we've done, one of the things that we learned is we've now separated those two. So we have a contract with the patient care record company, and that's a one-way street. We're just paying them money. But the billing company, we should be getting money back, right? We should be working with them to get money back. In fact, the way this works is they get a percentage, and the better they do on billing, the higher their percentage becomes. And that's just the way that we're doing it. But we're a lot smarter now with the experience that we went through, and the people that are doing our billing now are medical billers. They're not governmental billers. So I told you that was going to be riveting, and I see so many people came and sat and took the seats. So questions? Well, right now our rate of return is really low because we actually had a period where we were so dissatisfied we thought we might be getting ourselves in trouble, so we stopped billing. So right now it's zero. We're not recovering anything. We're in the middle of this transition right now. So you know, I can't tell you. I want to say that we think that we're going to get. There have been so many numbers that have been sort of thrown back and forth in these conversations that I really shouldn't say anything, but I think we were down in the 20 to 40% range, and we're hoping to get back up to 50, 60% range. That's where, again, I think that's where we're headed.
You know what the national average is?
I don't. Do you guys know what yours is?
Yeah, we did a round table, one of our Eagles. Between 0 on the low end and probably 60 or 70 on the high end.
I don't think anybody's at 70 yet.
Yeah, we're hoping that we're going to get up to over 50 with our new setup.
Denver, we're about 30%.
30%.
Most are less than 50.
Yeah. Do you know what yours is in Albuquerque?
Yeah, ours is 0. We don't.
Oh, yeah, that's right. You said 0. You don't bill.
I know what ours is very.
That's the problem we were running into in our city. We were at 33%. The city looks at that and says that's terrible, you know. But national average, it's good. It's 17,000 transports, and you know. But then they started focusing on just your narrative, because most billing agencies only bill on the narrative. They don't look at all the drop-down boxes in your EPCR. So I sit on a state coordinating committee. They're trying to get data. They want data. They want data out of drop-down boxes. They don't want data out of a narrative. And all these agencies are pushing and pushing and pushing for a narrative so that they can bill. And we can't get any data on, because they don't bill by data.
In our situation, our billing company was only billing out of the drop-down boxes. Right. But we had drilled in our guys to write these narratives because when it goes to the hospital, you know, the hospital staff don't look at the drop-down boxes. They read the narrative.
The only thing you can use is an error. That's the
Right.
irony.
Right. That's yes. That's.
Another lens of looking at that is what is your EMS operating budget and how much do you collect? What percentage of that budget are you recovering? And you know, every city's a little different. In Chicago, our EMS collections go back into the city coffers. They don't go into the department. And so, but in terms of a negotiating position, if you can put it relative to your operational costs, that number can be as high. I mean, ours is upwards of 80%.
So there's another little twist to that. Part of it is, you know, you get to bill, you know, Medicaid, Medicare, they pay sort of on these regional rates. And the regional rates are sort of based on what the regional charges are. So on one hand, you want to maximize what you charge, but you have to be able to justify it because your government, you know, you're not Bob's Ambulance, you can just charge whatever you want. You got to be able to justify it. So then what we did in Houston was we came up with this equation to try to figure out how much of the fire department budget was attributable to EMS. In other words, if you took EMS out of the department, what would the cost drop? And boy, you can get real creative, and you can really push that higher. You can push that low, and if you make it low, then your percentage of recovery gets better, but then your ability to bill Medicaid. So it's like I said, this is not straightforward. It's complicated. You need to get the pros involved. That's probably the bottom line.
Speaking to the workers' comp, what we're seeing here in Colorado right now is that I'll just give you one example. We got a presumptive cancer bill, so firefighters get cancer, and then it's under workers' comp, And then what the cities do is push it off onto your medical. And so what happens is the next time you go to negotiate a contract, your medical, they say, oh my God, your medical's out of whack. It's really went high. And you really got to work on making them keep it under workers' comp. And the city doesn't want that because their worker comp rates go up.
That's exactly right. But somebody's got to be watching this stuff.
Yes.
Somebody's got to be paying attention to this stuff or you're going to get burned.
I think you get that, something like that in your contract if you're able to do that. Because we have heart and lung in Rhode Island, we have it in our contract.
Thank you very much, Dave. That's outstanding. Appreciate it. What?
Mike.
Mike, you want Mike? Do you want me talking to Mike?
I think they're.
Hi, I'm Mike. Sorry. Just wanted to let you, by the way, I just found out from my assistant that the next Eagles meeting is going to be held at the Intercontinental Hotel in Dallas, and it's going to be on February 28th and the 1st. And I think they're offering like great rates, like a $100 hotel rate or something like that, which is amazing, like $99 or $105, something like that. So the way you look it up, I think Ray is not here, right? But I think he said this morning you go to www. What is it? It's Gathering of Eagles.
Gathering of Eagles.
All one word, .us, right? Something like that.
I believe that's correct.
Yeah. Okay. Whatever. So, but you'll see it, or just look me up, and we'll try to get you the date, get you plugged in with Gail and all that thing. And it's really, huh? Oh God, yeah. It is. We have a closed conclave. This is how it got started. We have a closed conclave between the 40 or 50 of us, and then we serve as a focus group from like U.S. senators or Homeland Security or Heart Association. They all come in and want to tap us, or industries want to present their latest stuff to us. We give them feedback. But when that came up, a lot of people said they wanted to sit in those meetings, but it just wasn't going to work. So we decided just to have an open session. So we have, just like we're having here, we have these like sort of 10-minute bullets, and there's about 40 talks over 2 days. Mm-hmm. And then I'll be on that Friday the 28th and March 1st, the Saturday. I think the hotel's got lots of rooms. It's just open to anybody. In fact, I would bring your medical directors along, is what we find, is that a lot of people are here often say, I wish we could get our medical directors on board with this. Well, that's the perfect opportunity to get them on board, for those kinds of things. All right, so with that, actually, that brings up an interesting segue. Thank you very much. And that is the involvement of medical directors. And over the years, medical directors have been everything since it's an advisor who just signed paperwork to people who are just like right there in your face, and sometimes too much in your face, right? But we're going to try to give you a little bit of better perspective about why we think the more you get involved, and I think that's what we heard a little bit today, is in getting the right people involved with the right temperament and mentality, I think is important. And so we're going to tell you about how we think that's going to evolve here. And with that, please welcome Drew Harrell back from Albuquerque, okay?
Thank you, Dr. Pepe. So we're going to start. So Doc in the Box, it is a burgeoning area within the pre-hospital EMS Medical Direction community, and I'll tell you why. And we talked, and as we came up with the title for this, Evolution or Revolution, and you'll see why in EMS Medical Direction, keep that in the back of your mind. But let me show you something while we're getting ready here, because it's exceedingly important to kind of look backwards into the historical record, if you will, to see where we came from. And I want y'all to notice here, this is, if I'm not mistaken.
Chances are that someone you know will suffer a heart attack this year.
Oh, that's working great. It was just on, wasn't it? So while we're working through our technical difficulties, we thought we were there. Let's see what we got here.
911 gets 3 to 4 calls for cardiac arrest emergencies.
Okay, what I want you to do, I want you to take the heel of your hand and put it in the center of the gentleman's chest, okay? Right between the nipples.
Someone has to start CPR within the first 4 minutes.
Put one hand on top of the other hand.
Electrical shock has to be done within the next 3 or 4 minutes.
The ambulance is coming. The ambulance is coming, okay? Just continue doing the CPR, okay?
If you go beyond either of those 2 time limits, the chances of survival fall dramatically.
They're there? Okay. All right, bye-bye.
Dr. Paul Pepe is Director of Emergency Medical Services for the City of Houston. a hands-on supervisor in the 911 centers, the field, and trauma centers.
MD1 to ambulance 58. What's your exact location right now?
You had a great card.
Even in the best of systems, the fastest you can get anybody to you is about 3.5 to 4 minutes from the time of a collapse.
Houston Fire and Ambulance, what's your emergency?
Yes, need an ambulance. The lady across the street is in the, there's a gentleman in the car. He's having a heart attack.
How old is he?
I haven't the faintest idea. I was walking out the door. The lady said to call 911.
You don't know whether he's breathing or not?
No, I do not know.
MD1, I'm going with 33.
When Dr. Pepe arrives at the scene, 3 cardiac arrest teams are working on 49-year-old Walter McLeod in his front yard.
He basically had a sudden short-circuiting of the electrical system of his heart. He had sudden death. He keeled over.
Whoa, look what we got here. In the complex.
Let me get.
I barely got to.
Keep a line on my arm. Get a pole. Everybody, they supposed to be here clear out. ID established. Give me my line.
Give me one on him. 2 milligrams of energy right away.
Bro, lidocaine.
Come on, let's go to the CPR a little bit. Go to the CPR.
Pick up close whenever he pulls.
That's fine. We wait punches, right?
Yeah, no, I mean, whenever he kicks up.
That's fine. Let's keep it up.
If we can get the rate up, we'll be in good shape. Put Astro in there?
I want aspirin after I get the epi out.
All right.
Let's go. Don't lose that line. And then squeeze the bag in, try and lift the arm up in the air.
Okay. Got it.
Here's some things, Kim.
Cap on 7. Show FE on board. 1 milligram.
927?
Don't lose the line. Lift the arm up in the air. Squeeze the bag in. Run it for 30 seconds. Now get it. Okay. Is it running good? Okay, stop.
Pay very
CPR
close
and
attention
stop
to
bagging.
Paul's hands.
Okay. Stop thinking. Okay. Go ahead.
Complex.
You got pulses now? Yeah. Good. Okay. Keep doing the CPR. Let's get a strong radio.
He just slumped over in the car. We got him out and gave him CPR. And that was it. Is he breathing?
How you doing now, Dale?
I got a radio.
Okay, good. Package. Okay, we got him. Okay, start getting the blood pressure. Okay. Start to take a breath.
Yeah, there he's going now.
Still there, Dave? He had just left a Michael Jackson concert. He
His
forgot to
friend
tell us.
did CPR immediately.
So,
Hang on, baby. 3. Yeah.
the rest of this walkthrough, we have return of spontaneous circulation there and some transport. But what I wanted to do was kind of give you a historical perspective, because one of the big things that on the physician side that we have recently had come about is all this hoopla about field physician response. And Chris and I have been talking about this at length because, I don't know, are y'all aware of the new subspecialty EMS certification exam for emergency medicine physicians? Who's aware of that? Let me see a show of hands. Well, Clement, you don't get to count. And Chris, you don't either, and neither do any of us. And no, okay, all of y'all. So let me tell you what's happened. So we have worked for a very long time. Some of the individuals that were here, Dr. Pepe and Dr. Fowler, obviously, and Dr. Pierce as well, worked tirelessly for a very long time. We now have available to emergency medicine physicians through the American Board of Medical Subspecialties and the American Board of Emergency Medicine subspecialty certification in EMS medicine. That will be available for us to spend additional amounts of money this October for the first sitting of a subspecialty board exam in EMS medicine. Just like cardiologists, just like neurologists that do subspecialty certifications, any of those things. We have moved much closer to reintegration within the House of Medicine, particularly on the physician side, and that is a big deal that was a long time in coming. Now, some of us have had this discussion where perhaps we're like the dog that chased the car and now we got the bumper. Kind of what do we do with it that we've caught up with it, and we'll talk through that why. But the biggest thing, and there's a lot of language on here and I won't belabor the point, but obviously integration of pre-hospital patient treatment into the continuum of patient care, that last sentence, and care provided to patients in the pre-hospital environment. And where this could have an effect for you on the pre-hospital side is that EMS is now, from the physician side, a clinical subspecialty with a practice in the pre-hospital environment. No longer administrative, No longer that doc that, as Dr. Pepe said, signs your license, or the doc that deals with the complaints, or the doc that calls you when they have something that's gone wrong. This is a practice of medicine in the pre-hospital setting that really has a very, very robust focus. I think some of us might argue that we might have created a bit more of a monster than we expected with the subspecialty certification exam, but is going to have a huge effect on the newest upcoming generation of EMS physicians, because it's not desk jockey work anymore. The physician there on the bottom, your bottom left, is one of our most recent graduates. That's me up top when I was doing my fellowship in a Guard Blackhawk. And I think if you'll look here, these are two of our most recent fellows coming up. This is practice of pre-hospital medicine with providers in the field. This is an expectation and a requirement for us moving forward. And how does it affect you? Is I think that you will see a lot more of a development of more robust field physician response. I don't know if anybody see this article in GEMS in this past June. This is my shop in New Mexico with the EMS Medical Direction Consortium. We have a collaborative approach in coordination with our EMS fellows for providing very robust field physician response available 2 deep, 24/7 a day, anywhere in the state of New Mexico. We have 5 vehicles available to us because the growing change in pre-hospital medical direction, I believe, and moving forward is going to be much more aggressive field physician involvement, because we'll talk about why that's the case. And as an aside, how many of you, not the knuckleheads up front here that are always throwing in things, and Clement, you're in the back, how many of you have a field physician or a medical director that you've seen in the field in the last month? That's actually pretty good. You get to put your hand down. All right, how many have never seen their medical director in the field? Just 1, 2, 3, okay, so, and what about the rest of y'all? Have you seen them? You don't have a medical director? No, I'm just, so that's actually surprising. That's so about half, maybe third of y'all. So I think that is that's a benchmark for a much more aggressive and progressive system. And moving forward, as more of us are coming out of these EMS physician training programs, you're going to see much more of an environment. So hands-on, and what's the best way to keep a physician involved on the scene is give them something to do, and they love it when I show up, but I get to hold things or go get things. And that's what we're there for. We're a support function, at least in my mind, moving forward. It's a resource. It is an opportunity to ask questions. It's obviously a very short truncating of the need. If you have an opportunity or a requirement for contacting of a base physician, if we're there, it's, hey, doc, yeah, that sounds good. We know what's going on. And I'm trusted enough of my folks that they will take me and throw me off the side of a 7-story drill tower, and they have yet to drop me. So I think what I'm doing is working from my side. But the implications, I think, moving forward here for fire and EMS agencies, and it's either you're involved with it on the training perspective, like we are in Albuquerque very heavily, because I have, in essence, an associate fellow, associate medical director that's one of my fellows that's assigned directly to my department, as we do with one of the other departments, is there's a very heavy focus on the field practice and response, the EMS research and education moving forward, and I think that as we move from 2000 and where we are now, 13 forward, there's going to be a maintaining of that expectation because those of us that are doing this like what we do, love the pre-hospital practice of it, and really are going to, moving forward, have a much greater expectation of maintaining that field presence. And what it does for y'all on the agency side is allows you to probably start to much more heavily build upon the opportunity to have physician involvement on the field, because it's much easier to stave off problems, identify concerns, and develop better systems of care and better protocols and better outcomes when you have a very, very hands-on approach and embrace that physician involvement, because there's going to be a lot of us moving forward that are going to be much more willing to do that because that's how we've been trained. But is it an evolution? Or is it a revolution, as Dr. Pepe liked to say here, coming back? And there's a lot of names on here that you'll notice that are actually sitting around in here. And it really started back in the 60s, Dr. Pantridge in Belfast, Northern Ireland, with the mobile intensive care unit looking at primarily, obviously, out-of-hospital cardiac events. Dr. Cobb in Seattle adopted that very quickly thereafter, looking at it in Seattle in the Medic 1. And then Dr. Copas and Dr. Pepe was there with the Medic 1 program. You can just roll through it. 80s, 90s, and into the 2000s here, we've still had plenty of people. And I'm sure we'll have some comments up here when we're done it. But when you look back, and even using, that was in mid-80s was your clip? So this is not new, right? Evolution, I think, is probably the inappropriate way to look at it. It's a returning to our roots. Eric talked about it. You know, when we're sitting there with from emergency and everybody sitting there at Rampart, you know, we worked very hard beginning to, we've been here before, right? That's Pepe, and that's Houston down at the bottom. But if anybody can find me that Volvo with whatever's on the door, I'll pay you money. That's in Pittsburgh, and mid 80s, if I'm not mistaken. Yeah, I'd love, if nothing else, just to have it sitting in my yard. My wife would love it. So the literature, and this is back in the mid 80s, the role of the physician in the pre-hospital setting, Dr. Stewart and Dr. Pepe, commented upon the initial very intense involvement of field physicians in the early infancy of EMS, and the fact that that field presence and builds credibility and allows you to uncover developing problems and issues with your system and really where it happens, where the boots are on the ground. That's important. But unfortunately, that did kind of slowly start to come apart. 93, prospective study looking at out-of-hospital cardiac arrest after the implementation of a very robust field physician response at times 0 and 5 years. The VFib arrest rates went from 0 to 21%, with everything else having a decrease in budget, paramedic time, and paramedic numbers and response times. And I think the conclusions there directed, you know, future efforts at properly training, certifying, and establishing appropriate positions for physicians who specialize in EMS supervision. This is 93, 20 years ago, almost to the date, when we finally got our EMS subspecialty board exams approved and ready to rock and roll. It's a little 19 years since that went into effect. And then Dr. Pepe talked about this earlier. So Ed Rock and actually Fowler as one of the co-editors for the Medical Direction of EMS systems book for NAEMSP, really, I think this nails it and really takes it home for us. No longer that doctor who signs off on your protocols, and no longer that doctor who goes over the complaints. Science and medicine, if nothing else from today's talks, you know, we've hit on it. Clement, Eric, Chris, all of us have hit on the really rapid changes in EMS, the practice expectations, and the change in the healthcare environment. And you have to have an adaptation for new delivery models, and that involves a lot more robust physician involvement, because if not, we are not going to have a seat at that table. And if we're not there, if we're not that pivotal point of collaborative efforts for all of the things that we're trying to do, we will not have the say and the part in the moving in the movement towards much more robust medicine that I think we would want. And I think, you know, if you look at advanced practice paramedicine, community paramedicine, public health, mental health, the non-emergent service delivery models, alternative destinations, all of that is going to require a much more aggressive, much more proactive approach from medical direction. And if we on both sides here, that's why it's much more interactive. And I think what Dr. Pepe does with the Eagles group, and we being here to say that it is not us versus them, it's all of us together protecting the environment, protecting our jobs and our members, and protecting and providing the best care moving forward is what you're going to need to do. I'd like to thank you. That's my fancy little truck and one of my fellows there on the side, Daniel Stites with one of my EMS captains. If anybody has any questions, I'd be more than happy to talk about it, but I thank you very much.
Thank you.
Yes, sir. So for the board certifications, absolutely. I think that so some training programs, and y'all help me if I'm wrong, but I believe that there are a couple of different pathways for some fellowships will allow. Oh, you're going to go over that? Okay, he's going to answer that question. At my shop in New Mexico, you have to be an emergency medicine trained physician to do our EMS fellowship.
And I've had some fellows that I were in who are surgery, they're going to trauma surgery, and that was kind of helpful in some ways. And they actually helped me with a lot of my tactical departments as well. One of the things I was going to say was, what I feel was important was I really could. I remember early on when I was out in the streets, there were people who were saying things at high levels in the department, making decisions about budgets or why people were doing something a certain way, or they're using up too much of the material. And I was down there, and I was actually in those meetings. I said, well, the reason why that's happening is because of blah, 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 because I was witnessing it. And so I knew what everybody was going through, and I can also see what they needed during those periods of time. So I had some access, and that was helpful. But what was most important is you had someone who knew the procedures, they knew what the police's jurisdictions or what the role was, or if they, or is this, you were just a familiar sight and a familiar face. You're integrated into what operations are. You had a respect for the authority lines and the chain of commands, all those kinds of things that we need to know about and who does what, as opposed to I'm a doctor and I just show up at a scene somewhere or at a disaster. So when a disaster happens, you want people who are there on a day-to-day basis helping you out, et cetera. And that's just on a simple level. That's one of the things we're talking about. But we think that people can't write your protocols well. We think they can't do the training right unless they've walked the walk and been out there with you. And so that's a little bit of what I think Chris is going to get into, is how we're trying to frame this fellowship so that you have a better chance in the future to have people who were trained in these very areas that we're talking about, so they could be a help to you and not someone who's a hindrance or hasn't got a clue what's going on and what you do. Okay?
So yes, that's a good segue into what we're going to talk about next. I'm glad he asked how many of you are aware of the EMS subspecialty, and that's kind of what I want to bring forward here today. So now everybody can answer that question. Yes, we are aware of the subspecialty. So this is the reality of the new specialty, and it is very exciting. Now, it does have implications on all of us, and I think it's important to acknowledge both the very positive implications that I think we've already started to allude to, and then maybe there's a few that might not see these as positives. So we need to talk about that as well. So we are now approved by, as Drew said, the American Board of Medical Specialties. Actually, it was back in 2010, and now we've spent the last 2 years essentially getting up to where we are now ready to give the first exam this coming October. It is the 6th subspecialty, along with toxicology, pediatric emergency medicine, sports medicine, and actually we do have hyperbarics and palliative care in there as well, but we are now the 6th subspecialty. But now, after the exam, assuming that some of us pass that exam, then we will actually be board certified in EMS. So what does that mean? You've heard board certified surgeon, board certified emergency physician, all these things, but now there'll be a board certification in EMS. And basically the idea is to address that exact issue, is so that you can say if somebody is board certified in emergency medicine, or excuse me, EMS, they will now have had to focus on the very specific areas that we have talked about. And one of the main emphasis was for creation of this subspecialty is the clinical practice of pre-hospital medicine. It's getting out there into the field. It's not sitting at a desk signing things. It's not just basically looking over and approving protocols. It's actually getting out there, taking care of patients in that environment, learning what that's like so we can have meaningful input and involvement in our pre-hospital systems. So the certification program will be through the American Board of Emergency Medicine, ABEM, and it's designed to do exactly what we talked about, standardized physician training and qualifications. So if agency over here has a board certified EMS physician as their medical director, it should have the same qualifications, same basic training and ideas and background as, now obviously we all have different backgrounds and experiences, but the same training as agency B with an EMS board certified physician. And think about that for a minute. I mean, think about the agencies that you're involved with and that you know about, and how varied the medical directors, physician advisors, however you put them, are. The idea is to try to have some degree of consistency here, some degree of standardization. We have them for EMTs, paramedics, every level of practice physician. Why shouldn't we have one, a standard for EMS physicians? Improve patient safety, enhance the quality of emergency medical care, and facilitate further integration of the pre-hospital patient treatment into the hospital setting by being sure the folks that are saying they're board certified in EMS actually have some sense of what they're doing. So eligibility, you need a current primary board certification issued by an American Board of Medical Specialties member board. Emphasis here, it does not have to be emergency medicine. Some of you do have EMS physicians that were initially trained in medicine. We have some of our Eagles that were initially trained in medicine, surgery, and other things. So it doesn't have to be emergency medicine. So if you like that person, you can tell them they'll be eligible for this. If you don't, you can tell them they're not, and they may never know the difference. But it actually doesn't have to be in emergency medicine. They need a medical license in the state that they practice. That makes sense. And in fact, and if they cross over states, they need medical licenses in both states. And there are 3 application pathways, what Drew was referring to. There's the practice, which many of us are going to be in. There's the practice plus training, which some of us will be in. That what Drew will fall into. And they're just straight old training, which doesn't apply to anybody yet, but will starting this last July 1st, for anybody starting a fellowship this last July 1st in a accredited area. And I think most of us, I know Denver and New Mexico and others are accredited areas, so fellows that started actually a year ago last July will now qualify for this practice. I'll tell you what those basically are. So the EMS practice is within the previous 6 years. Think about it as your medical director, your physician advisor fits this role. Within the previous 6 years, 60 months, 5 years of EMS practice. That each year needs 400 hours a year dedicated to EMS. That doesn't mean in the emergency department, working clinically. It means dedicated to EMS as a level of an assistant, associate, or medical director of an EMS agency with patient care responsibility or direct patient care provider. So that means getting out there. It means not just sitting at a desk, it means getting out clinical practice. And we sold this subspecialty on the clinical aspects of it. So it really does emphasize getting out into the practice. The other application pathway is EMS practice plus training pathway. So any fellowship up until this past year had to have been unaccredited because there wasn't such a thing as an accredited, ACGME accredited fellowship prior to this. So it would be any, and that's, I'll use you an example. That's what you went through 4 years ago. 4 years ago? 5 years ago. So you have to do that. It has to be 1 or 2 years of a fellowship plus 24 months now. It's not 6 years, but 24 months of an EMS practice within the past 6 years. And that fellowship needs to be 1 year in length and based on a core curriculum. So that's where another group of folks can now participate and sit for the exam. And then the final is the EMS fellowship training with an ACGME accredited fellowship. Again, our 2 fellows that just graduated this last June 30th are the first ones, at least from Denver, and I think the first ones anytime for that time period that can actually apply for this. They can directly sit for the exam. They don't have to have that clinical practice because it was built into their fellowship based on the fellowship curriculum that's mandated. First exam will be this fall. We're all sitting for it. It'll be the end of October. Dave Pierce is studying for it right now. Actually, he's studying for his other certification boards, but we'll be studying for it for October before our exam. They don't have oral boards planned now, thank goodness. And it's based on this. And where is Ray Fowler? Can we curse Ray Fowler? Because it's these 4 books, and boy, I can't believe they couldn't have put this information into one. They could have made it thick. But 4 books, that's the core curriculum that the exam will be based on. Recertification every 10 years, and there will be an assessment of practice performance, being sure these folks are getting out into the field. Fellowships that are accredited will be 1 or 2 years. Most of them will be 1. Emphasis will be on supervision and clinical experience, as we talked about. The RRC, the Residency Review Committee in Emergency Medicine, will accredit it. Program requirements are a curriculum, there'll be faculty, and there are duty hours. It's fairly well regimented. We were woeing the ails of now that we no longer have that flexible fellowship that we can do most anything we want with. It's fairly rigid what is required for this. So what does this mean for you? Well, it means that probably nothing this year, next year, and in the immediate future, but it does mean that the expectation will change. And that we're there, or coming up to be there, where the expectation will be for agencies that are commanding respect on the cutting edge are going to have medical directors that are EMS board certified. And that, I think, is a great thing. Now, let's be very honest. What do we use our medical directors, physician advisors for? Sometimes it's to stay out of the way. And that's going to be more difficult now. There are some places that take advantage of the fact that basically anybody can sign up, sign off on the right papers, and be done with it. Now, in the end, I think we really are hurt by that, because if that's the message we give, that's exactly what you get. You get somebody who doesn't really know what they're doing or really have a good concept of what the implications of what they do are. This is geared specifically to change that. So hopefully, we will embrace this. hopefully we will say, this is an opportunity for all of us. What I've heard a lot of comments in between sessions is, God, I wish my medical director would get out there and see what we do. How is it that he or she signed off on this protocol when there's actually no practical way we can do that? And why didn't they know that? These are the real frustrations that I think our EMS providers are, at least they're expressing to us, and this is specifically trying to address it. Now, you asked a wonderful question the other day, or for Clement's talk, about what does a physician do? If you have a physician who knows what they might be able to do, it's exactly what they could, in a mass event like this, they could authorize refusals, take intoxicated patients that otherwise have to go somewhere and put them in an area where they can monitor it. They could allow medics to go outside of what would be a standard protocolized scope. And in some cases, we talked about in disaster where you'd have an alternate care site, they could potentially open up a world of possibilities. And we talked about advanced practice paramedics. You could do that today if a physician who knew what they were doing fill in that role. The opportunities are there. They really are, and they could start right now, and has started in a lot of places. But it takes this. It takes a baseline expectation of what our physicians are going to go through, what they're going to understand, what they're going to experience, what background they should have before they can start to say, I am a medical director of an EMS system.